morning to everybody, and welcome to this special SEUD event. This is a webinar dedicated to the iron deficiency and anemia in women. SEUD is a new society which is interested in high scientific visibility, is a large worldwide network, has a big annual congress, and focus also on education and young generation. The key words of our society are disease, endometriosis, adenomyosis, uterine fibroids, and heavy menstrual bleeding, abnormal uterine bleeding. This is why today we are here to discuss about the abnormal bleeding. The society even though it's a young one, has more than 1,000 members, 36 international scientific society partners, 15 patient support groups. This is a characteristic of the society, and many email database and social network community. The next Congress will be in Stockholm next May, and we will have a discussion on endometriosis and uterine disorders. The today meeting is very special because we have 3 different speakers and with different specialty. Hilary Critchley, professor of reproductive medicine at the University of Edinburgh, will be the first speaker, and she will speak about heavy menstrual bleeding and iron deficiency anemia, giving us an overlook on menstruation and heavy menstrual bleeding, impact on menstrual bleeding components, HMB and iron deficiency, communication between anemia patients and public, and then the discussion will be also on Palm-Cohen and FIGO system, finally with a diagnostic SLAP on HMB. The second speaker will be Professor Arieh Chander. He's director of Team Health Research Institute, emeritus at the hyperbaric medicine anesthesiologist. There's another discipline. He will speak about the patient's blood management in obstetric gynecology, and particularly the discussion will be on patient blood management, why defining the unmet need, defining the patient blood management, and what occurs in gynecology and obstetrics as anemia and cornerstone of patient blood management. The third presentation will be just some patient profile from myself, and how we will discuss on young women, postpartum hemorrhagia, and heavy menstrual bleeding in premenopausal women. So we hope to attract your attention and give you the update information on those 3 sets. And the first speaker, as I mentioned, will be Hilary, and she will have her presentation now. And please give your lecture.
So, hello everyone, bonjour. We are here in Paris, and it is a pleasure to be part of this SEUD webinar. So my topic is heavy menstrual bleeding and iron deficiency anemia. These are my disclosures. So, as already outlined, and I'll just go through them again, the objectives of my short contribution will be to consider menstruation and the symptom of heavy menstrual bleeding, the impact of menstrual bleeding complaints, consider heavy menstrual bleeding and iron deficiency anemia to introduce the following 2 presentations, highlight the importance of communication between patients, those who care provision falls to, and importantly also the women and our public. Fundamental is the ability to characterize our patients, and this requires classification systems. So I'll share with you the Palm-Cohen acronym and our 2 FIGO systems. And then finally, hopefully provide the transition to our next speaker, who will focus more on the importance of iron deficiency anemia and diagnosis steps. So, I want to share this quote with you. It's from an excellent publication last year from Professor V.G. Thomas in Canada, and I read, "Half of the world's human population menstruates, and the total time experiencing menstruation is at least a quarter of each woman's reproductive years. Menstruation has long been a taboo subject for different religions and cultures based on ignorance, prejudice, and false information. Many women experience physical and emotional discomfort during menstruation, and this malaise may be amplified by prevailing archaic social attitudes towards menstruating women. It is very, very important that we open the conversation about menstruation, about periods, because this has for too long been a taboo topic. And of course, menstruation is a physiological, natural event, but it is when menstruation begins to impact a woman's quality of life that we have to think about menstrual disorders. And heavy menstrual bleeding, and we do request that terms such as menorrhagia and dysfunctional uterine bleeding become discarded, and we talk about the symptom about which women complain. And heavy menstrual bleeding has been the focus of a NICE guideline in 2007, revised in 2018. And importantly, from our own Royal College of Obstetricians and Gynecologists, the topic of a very important national audit, which highlighted the prevalence of HMB, affecting 1 in 4 women, affecting their quality of life, huge economic implications. Medical choices are included in the management armamentarium, but for some women these may be ineffective, unsuitable, or poorly tolerated. And of course, surgery removes fertility preservation. And as women in many parts of the world delay their family or wish to restrict the number of children they have, fertility preservation and the preservation of the uterus becomes ever important. And so we clearly have an unmet need, highlighted here in some examples from that heavy menstrual bleeding audit by the RCOG. In the first year after attendance at gynecology clinics, over half who received oral medication switched to a different treatment, often an intrauterine system or surgery, and a third of those given an intrauterine system switched to a different treatment in the first year, often surgery. The audit reported that at 1 year post-referral, only 35%, so that's only a third of all women, including those who received surgery, were satisfied or felt better at the prospect of current menstrual symptoms continuing as currently experienced for the next 5 years. Again, emphasising the importance of recognising disorders of menstruation and the unmet need. So, we have heavy bleeding, and it is an important contribution to iron deficiency anemia and iron deficiency anemia. And I just want to share with you this global estimate of the prevalence of anemia in women of reproductive age. It's from the WHO. The website for the reference is on the slide. And you will see in those very dark red colours a prevalence of 60%, particularly in some continents such as Africa and Southeast Asia. So this is a worldwide problem. Treatment of heavy menstrual bleeding-associated iron deficiency anemia crucially should include identification of underlying causes of HMB and correcting anemia with iron replacement. The obstetricians and gynecologists, many of you will be those we hope in the audience of this webinar, are ideally placed to diagnose, treat, and if required, refer patients for HMB-associated iron deficiency anemia. The symptom of HMB is a leading cause of iron deficiency and iron deficiency anemia in women. And on this graph, we see some of the many causes of iron deficiency anemia, but it is heavy menstrual bleeding which is particularly prevalent. And we will hear later about the importance of iron deficiency anemia in pregnancy. So, The prevalence of anemia and iron deficiency anemia in women and its clinical burden are represented in these diagrams here, and I acknowledge my colleague Mac Munro from Los Angeles for sharing these images. The global prevalence of anemia in non-pregnant women is 30%. Among postmenopausal women, we should remember it can also be prevalent, coming close to 10%, but overall iron deficiency accounts for 50% of all anemia cases worldwide. So let's talk about abnormal uterine bleeding and the symptom of heavy menstrual bleeding. If we're going to improve communication, whether it's for clinical study interpretation, physician to physician, or physician with their patients. And many of you will be aware of the 2 FIGO systems concerning abnormal uterine bleeding for women in the reproductive years and the international consensus. And I just share with you the journey that we've taken. It's been a global journey. It began in 2004 in Paris with our hematology colleagues. The first major consensus meeting was in 2005 in Washington. It's difficult to believe that was nearly 15 years ago. And since then, we have revisited and refined our nomenclature and classification system at the FIGO meetings in Cape Town, in Rome, at a SEUD meeting in Singapore in 2017, in Vancouver in 2015. And this topic will again be revisited at the SEUD annual meeting in Stockholm in May, and then in 2021 when FIGO visits Australia. And importantly, this has had representatives across the world from more than 25 countries and been endorsed by many obstetric and gynecological societies and leading obstetric and gynecology journals. So, what are these 2 systems? Well, we have a nomenclature system and we have a classification system. The nomenclature system importantly defines normal and abnormal uterine bleeding in the reproductive years, so we talk the same language between physician and with our patients. And then we have the classification of possible causes with the acronym PALM-COIN. How do I want to just transit to the next contribution? Underpinning always is determination of cause. We may be helped by FIGO systems. 1, we must remember that abnormal bleeding and the symptom of heavy menstrual bleeding is so under-recognised at times as a problem and underreported by women. There are many studies now where women will avoid sharing the fact that bleeding is the reason they don't want to be in the workplace or transfer other duties to their families. The FIGO system 2 is our classification system, as I've just described, with the acronym PALM-COIN. We need to integrate findings, patient counselling, listening to our patients is crucial, and we need a management plan. And I just share this comment because I believe it will be revisited in subsequent presentations during this webinar. Anemia is important to recognise, and even if we have surgical interventions for the symptom of HMB, it may impact on operative morbidity, perhaps even mortality, hospital length of stay. And these are all more prevalent, as you will hear shortly, when hemoglobin levels are low. So thank you very much for your attention. I'm pleased to be part of this webinar. We hope there'll be opportunity for questions later. And I hand over now to my colleague, Arieh. Thank you.
Thank you, Hilary. Perfectly in time. Congratulations. It was a very clear presentation. And now we move to Arieh who will he's our special guest because the SEUD is a gynecological society but open to interdisciplinary aspects. So to have one of the most famous anesthesiologists in the world is our pleasure. So please, it's your time now.
Well, thank you. Thank you very much. Thank you for having me. Clearly, it's hi to everyone, but I just want to mention that this is clearly a pleasure and honor to share the webinar with my colleagues. So I'm going to switch gears a little bit and talk about patient blood management in obstetrics and gynecology. We heard a little bit about heavy menstrual bleeding, but keep in mind again that we're trying to circle around anemia during the life of women. So with that, this is my disclosure slide. As you can see, we work with industry, but it's all to make things better for our patients. So just very quickly, I'm going to go over the objectives that already were listed, but I think it's good to remind the audience and really address the question of why do we need PBM, which is patient blood management. Essentially, we're defining the unmet need, which we present with transfusion medicine, which is the default today. In fact, I could spend the rest of the 15 minutes talking about transfusion, which is a therapy, without ever mentioning the disease that we're treating. And this is why we need to define patient blood management, which I'll do in subsequent slides. Again, we'll address patient blood management in the OB/GYN population and look at some of the issues that we have with anemia. And again, anemia management is the cornerstone of patient blood management. And again, we don't resort to the default of transfusion, but we're looking now at etiology and the proper treatment. And as you could see, we'll end up with some supportive data in terms of where we have patient blood management in the OB/GYN population. Now, the status quo today is a transfusion, but transfusion in that sense, as I mentioned already, is a therapy and does not follow the medical model. It's really product-based. And if you talk to our colleagues that deal with transfusion medicine, their issue is delivering blood, which is safe and also available. There is a lot of imbalance between the risk of blood transfusion and the benefits. We're still trying to get our arms around this imbalance. There's also inconsistency in the use of transfusion. Even though we have guidelines, many people do not follow them. And of course, as we know, there is ample data in terms of the negative outcomes associated with transfusion. Now, we do have guidelines, but the guidelines are one size fits all. That's an important issue in terms of trying to, again, answer the needs of each individual patient. And lastly, as we now know, that transfusion is an expensive modality, which we've never known until 2010, when we actually did the calculation, and transfusing patients actually is an increased cost for healthcare. Now, when we go to patient blood management, essentially, we're looking at disease management. That is the medical model. We identify first the disease, and for this discussion, we have anemia as a central disease. We identify the potential etiology or the causes of the disease. We need to understand the epidemiology as well as the natural course of the disease, because treating a disease early on may not be the same as treating it once again it's advanced. And we need to select the best therapy. And the therapy, again, may vary depending on the time we diagnose the disease. And then, of course, we address prevention. And lastly, we have to measure outcome both in terms of the disease as well as the intervention. That's very important. So you could see that the medical model is clearly the one that we need to address when it comes to treating women and anemia, as already discussed. I bring this slide because I think it's important for us to understand the impact of anemia, not just on the individual patient, but globally. As you could see, the world today contains about 7.4 billion people, of which 2.3 or more billion people suffer from some level of anemia. It is interesting that anemia belongs to the club of being the fourth leading cause of years lived with disability, which is a measure of the burden of disease. The other three include cancer, heart disease, and diabetes. So you could see that this, again, has a significant impact worldwide. Iron deficiency anemia, again, affects about 1.5 billion people. From the bars that you could see on this slide, you could see, again, that women are the number one population that suffers from anemia. And second to that are children of 5 years or less. So again, this is a major concern, not just on the individual patient, as I'll show, but also epidemiological in terms of global management of anemia. This looks at iron deficiency anemia in women. This was a practical guide to detection, diagnosis, and treatment. This looks at women throughout their whole age and reproductive and post-reproductive and pre-productive too. I just want to bring to your attention the fact that we use the WHO diagnosis of anemia, which means that any women who has a hemoglobin of less than 12 grams per deciliter falls into the category. But keep in mind that hemoglobin is a concentration, and it is the red cell mass that differs between women and men. And therefore, we should have gender equality, which is the same concentration of 13 grams per deciliter, and I hope to see that change throughout the world. So again, keep in mind we should have a single hemoglobin for both male and female. I want to point to you that actually when you're dealing with the diagnosis of anemia, you may not just use laboratory tests, but there's also the possibility of using the therapy, meaning iron treatment, to again retrospectively diagnose the presence of anemia. So on this particular slide, I already addressed the 2 points. One, that we should have gender equality in terms of the diagnosis of anemia by the use of hemoglobin as a concentration. And two, suggestive also, if you don't have a laboratory test, that you could retrospectively diagnose anemia by the therapy. Here we talk about iron replenishment. Anemia in pregnancy is a major concern because, as you could see, the prevalence does depend a little bit on the geography, but there is no geography which is devoid of the presence of anemia in pregnancy. And again, iron deficiency leads again in this population too. And there are some significant consequences that are associated with anemia in pregnancy. This is one, looking at anemia and depletion of iron stores as a risk factor for postpartum depression, a devastating condition. And there's suggestion in the literature that intervention in this particular area may actually help in terms of reducing the burden of anemia. In the OBGYN population, again, we should move away from the default, which has been transfusion, for treating anemia in all causes, whether it be non-urgent or urgent. And again, we're trying to bring a more directed therapy towards the underlying condition or source of anemia, as depicted in this particular slide. Now, we know that annually there is a significant issue in terms of mortality associated with postpartum hemorrhage. What's interesting in this particular publication in the US is the fact that 70% of women have a high mortality rate, but this is preventable. And that's very important us to understand again that transfusion may not always be the answer. This again looks at prevalence of postpartum hemorrhage in the United States, but the green line represents actually transfusion. So you could see that there is a correlation between the two. Whether it's a cause and effect clearly is unclear. And again, we have to understand that transfusion per se carry risk to patients. In this particular incident, we're looking at the parturient, and you could see in red in the bar as a higher incidence of risks and adverse events associated with transfusion compared to the general women population who get transfused. Now, bringing it back to patient blood management, this is the Society for the Advancement of Blood Management definition, and it is the timely application of evidence-based medical and surgical concepts which are designed to manage anemia. Now, we have a disease, not just a therapy. Optimizing hemostasis, which is the balance between bleeding to death and clotting to death, and minimizing blood loss, which may not just be, again, heavy menstrual bleeding, could be phlebotomy in hospitalized patients. And all this has to improve patient outcome. Otherwise, it's all for naught. And you can see this is patient-focused. This is not, again, a product-focused concept. And these are, again, some of the elements that we have of patient blood management. But again, I want to stress that it's the patient outcome that needs to be demonstrated to achieve the goals of patient blood management. Now, again, best clinical practice is where we want to achieve. This is higher than evidence-based practice. You could see one of the things that we include here clearly is the patient's values and preferences. Now, evidence is a legal term. We like to use data-driven as well as adding the clinical experience. This is the best clinical practice that we can apply, which is what patient blood management aims to do. For the surgical population, we started off with 3 pillars. You could see again, preoperatively, intraoperatively, and postoperatively depicted in these 3 bars. But it also requires a multidisciplinary team approach, and this is why we're all here today at the webinar. You may not be able to see all the activities, but there are many, many activities that can be done which do not necessarily include transfusion as your default. Transfusion is there as a restrictive approach, but it's in its proper place, not as the leading intervention. You could see there's data on patient blood management and pregnancy and childbirth. And what I want to point out here again is the fact that anemia is central, because anemia not only has devastating impact on this population, but also can contribute to postpartum hemorrhage. And these publications, again, look at conservative approach in terms of transfusion. And that's because of the adverse events we already mentioned. Here's another publication with the same issue. You could see in the top list is management of anemia. Here again, management of anemia and restrictive transfusion is essential again for the health of these women. We published this to again alert the population that patient blood management is not centered on transfusion or reduction of transfusion. It's really centered around the patient with, again, the attention to the underlying condition that needs to be addressed and managed properly. There are guidelines. I'm just bringing you this as, again, as a resource in terms of guidelines for management of anemia during the pregnancy of women. This was from the NATA consensus. And lastly, I want to address the fact that transfusion does not stop bleeding and does not improve outcome in severe trauma, cardiac surgery, or GYN surgery, or OB bleeding. What we need to remember always is the fact that the bleeding needs to be stopped. And once the bleeding is stopped and the patient has shed blood, they may still remain anemic. And again, that anemia is iron deficiency anemia. And just because we stop the bleeding does not mean that we've treated the anemia. And I think that's the message that this slide would have. Now, there have been many organizations that have come up with the Choosing Wisely campaign. Each one gives about 5 recommendations. This comes again from the Society for the Advancement of Blood Management. And I just want to point out the last one, which again has to do with the restrictive transfusion because of the risks associated with transfusion, but it doesn't always address the etiology of the anemia that's being treated with transfusion. So I think the message is in that particular slide. And again, you're looking at the patients who have GYN oncology. What this slide depicts is in the red lines, the top and bottom are the standard deviations. What you see on the left of the slide is the pre-implementation of patient blood management. What you see below, again, is to the right side of the slide, is the fact that after implementation, there is a significant reduction in transfusion. But keep in mind, the aim is to measure outcome of patients and also to manage the anemia, not just reduction of transfusion. So in summary, anemia is no longer an innocent bystander. The consequences of anemia can be devastating already has been shown. Hence, management of anemia is no longer an option. It's a must. Transfusion is not the answer when it comes to anemia. We need to look at the etiology and address it appropriately, and patient blood management improves outcome and centers on the patient's needs. I want to thank you.
Thank you very much, Harry. We perfectly in time and very clear presentation. It's really worth it for SEUD to organize this webinar. The webinar is also interactive with the audience. Please, if you have any question for Professor Critchley or Professor Chandler, please arise. We will have discussion at the end of this presentation. As a webinar and the characteristic of SEUD, we have a great science with Professor Critchley. We had a nice overview with Arya Chandra on the other society, like Society for Blood Management and Anesthesiology. Now, we are also society, and the webinar is a good opportunity to show you some patients management, some cases. I will introduce you 3 cases because during women's life, we have 3 critical periods: the adolescence, the pregnancy during fertile age, and perimenopausal. Let's start from the youngest patient we had. I show you is a very young, 17 years old young woman, and she feels, you see here, from 8 to 12 months, from 1 year, she feels tired and weak, impairment school performance, reduced social life. What we have in general is the patient, this type of patient, they go to the general practitioner first. She went to and he discovered in the family hypertension. The mother had some uterine fibroids, no particular evidence. In the medical history, she had a migraine, celiac disease since 17 years old, and no previous surgery. So she is a young patient and the general practitioner said, okay, let's go on with our investigation. And anemia with 9 grams of hemoglobin was discovered, showed no other blood test, so she was considered anemic for malabsorption because of the celiac. Prescription of oral iron and folic acid, as usual in these cases. And then after 3 months, there was no improvement of general condition, and the hemoglobin was still 9.2. So even though there was an oral administration of iron, no major improvement. 1 year later, again, the 3rd time, the general practitioner said, let's do ferritin measurement. The ferritin was very low. The coagulation system was fine, was normal with blood test, full blood count and platelet was okay. So he decided to different iron tablets compounds and also start to think to the menstrual bleeding, because until now, in 2 years, he never discussed about the menstruation. So after 3 months with the different iron tablets, the hemoglobin was still 8.9, so very sad, very upset, and he decided to send for consultation to a gynecologist, speaking about possible hormonal derangement. So finally, a gynecologist consultation was prescribed, and the gynecologist again revised the story, the blood test for iron deficiency, the hemostasis disorders, hormonal assessment, and imaging. In our discipline, again, the menarche was 13 years old, and finally the gynecologist spoke about menstrual bleeding. She had heavy menstrual bleeding since 15 years old, and there were some interference of periods in the daily life. So, she never used oral contraceptive. Some dysmenorrhea was associated with heavy menstrual bleeding. So the gynecologist entered in the field of menstruation, and finally he asked to the patient to evaluate a pictorial blood loss assessment. This is prescribed by ECOG as one of the simplest methods to individualize the subjective pictorial blood loss assessment. Is a chart, and you see here this patient had 186, while the ECOG says that you have if you have uterine bleeding for more than 7 days and blood loss more than 80 milliliters per menstrual cycle, you may be diagnosed as heavy menstrual bleeding. So in this case, the patient was individualized as heavy menstrual bleeding. The hormones were normal: thyroid, the gonadotrophins, prolactin, and ultrasound. There were no major difference in the ovary. You see here on the light, the uterus was okay. So no major anatomical distortion. So going back to the Palm-Cohen classification, structural and non-structural, this patient was individualized as possible non-structural with very rarely coagulopathy, but in this case, most of the cases are related to ovulatory dysfunction, and 95% are included in this team, while iatrogenic is 4%. So our young patients may be considered as in the team, in this group of ovulatory dysfunction. And one of the treatment we used, because she had also celiac disease, was to give iron, but not in oral, but by infusion. And then we to replete, to complete to the iron. On the other hand, to reduce the menstrual pain and blood loss, we gave oral combined estroprogestin pill. So we have to replete iron with an infusion because of the inefficacy of oral administration of iron. And on the other hand, we start to reduce the blood loss. So this is an example of a young woman. And you see this is a study done some years ago. Most of general practitioners in European countries do not have any consultation for heavy menstrual bleeding. You see here 45%, 50% of European doctors do not ask for heavy menstrual bleeding, and this is a case. Only the gynecologist went to this patient, and also there was no treatment of heavy menstrual bleeding in the 50% of the patients. So this is heavy menstrual bleeding in this age is really not well underlined. More interest, as mentioned by Ariel, is on the fertile age and on pregnancy. Many women have during pregnancy. This is a 40 years old. She had a normal pregnancy, nothing to. It was induced labor because at 39 weeks she had a rupture of membranes. And she had a vaginal delivery after 12 hours from the induction. So nothing special in this case. Uterine atony, however, occurred. This is an example of unpredictable uterine atony. Postpartum hemorrhage more than 1 liter, 1100 cc of blood loss. And so uterotonics solved the problem. In association with the anesthesiologist, in our clinic we have a huge, very good collaboration with anesthesiologists, and it's really a good team. And however, the patient went from 10.9 to 7.5 hemoglobin milligram per deciliter. The day after, she feels tired, not able to take care of the baby. So we decide to have again a big dose of iron by infusion. And we could have an increase from 7 to 9, and the patient feels much better. So in a single dose administration of iron, we decide to replete again the loss she had at the time of delivery. So this is one of the possible, instead of using the transfusion, the idea was to give iron by infusion. The third, this is becoming an issue, as mentioned before. The obstetric history may be helpful in predicting which patient will have postpartum hemorrhage. Probably patient over 40, patient who had recurrent pregnancy loss, patient coming from assisted reproductive technology, which are very common now. The combination of 40 years old and assisted reproduction is becoming an issue in many clinics. And induction of labor can be predictive of postpartum hemorrhage. So now in obstetric care, the postpartum hemorrhage is one of the most important issues, and we are really improving our knowledge in collaboration with the anesthesiologist. What about perimenopausal women? This is a patient who is 47 years old, normal body mass index is slightly higher. She had heavy menstrual bleeding, irregular bleeding since 45 years. This is a critical age for women. Between 40 and 45, some women start to have irregular bleeding. Anemia was 8 grams per deciliter, failure of multiple hormonal treatment, because when we do gynecologist, the first approach is to give hormonal treatment. Let's see how is the history. The mother, at 40 years old, she had fibroids and was hysterectomized. The father had cardiac ischemic disease, a health brother, so no special. The medical history of the patient, she had autoimmune hypothyroidism. She's under treatment with L-thyroxine from 30 years. She had a body weight increase. She had, in particular, after 2 pregnancy, no abdominal surgery. Moving to the before pregnancy. So the history was to have a regular menstrual cycle until 40 years old, oral contraceptive from 20 to 32 years old for contraception, and 2 spontaneous normal delivery with vaginal delivery between 35 and 39 years old. So the story is very classic, nothing special in this patient. However, when she was 42 years, she started to have heavy menstrual bleeding after 2nd pregnancy. This is a common issue for gynecologists. When you have 1 or 2 pregnancies, she became over 40 and she had heavy menstrual bleeding. Menstrual bleeding 7-8 days, and very common, every 25 days. The onset of severe dysmenorrhea, the subjective pain score was 8, and interference with daily social work and personal life was really critical. So this is a classic patient we have in our outpatient clinic in gynecology all over the world. And what we do, she did 46 years old, she started to again oral contraceptive to reduce the bleeding. And she had a good response between 42 and 45 years old. For 3 years, so the problem was solved with hormonal treatment. However, when she was 45, the bleeding was irregular. This is again common. And she had hemoglobin 10, so, which is really anemic. Oral iron and folic acid was added to this patient in order to improve the anemia. So in gynecology, we have a good culture now in approaching these anemic patients. When she was 46, a progestin was given because the oral contraceptive didn't work, tranexamic acid, and again, oral iron and folic acid was included in the treatment. So there is a polydrug treatment, polysystemic treatment with hormones, anti-clotting agents, and iron. However, the hemoglobin remained 9.5, which is really absolutely not good for these patients. So the patients they come back very often to our office. In our practice, we see these patients, and sometimes they come also to the emergency because they lose bleed and heavy menstrual bleeding. And one of the most common now treatment is the use of levonorgestrel intrauterine device, and it was inserted when she was 47 years old. However, there was a spontaneous explosion of the IUS. So after 6 months, she lost all the possibilities because 9 grams again of hemoglobin, she remained anemic, quality of life very poor. And this is really a critical moment because we, as gynecologists from 42 to 47, we gave a lot of possible medical solution. But at the end, the proposal, because the PBAC you see is very high, the proposal was to do an hysterectomy because you see here, by ultrasound, an adenomyotic uterus was discovered, resistant to all the drugs. So the Palm-Cohen differential diagnosis pointed to adenomyosis, structural changes, heavy menstrual bleeding. What to do in this case? Severe adenomyosis, multi-drug resistant anemia, the hysterectomy was proposed. However, before to do the hysterectomy, decision, and the patient accepted, before to do, we decided, because the hemoglobin was very low and ferritin too, to give preoperative iron infusion in order to increase from 8 to 10 hemoglobin the day of hysterectomy. This was in the hospital. And so we could operate the patient with a good level of hemoglobin. And very recently, this is the publication which came out recently, 1/4 of women who undergo to hysterectomy or myomectomy are anemic. And this is preoperative anemia is an independent risk factor for postoperative adverse outcome, especially in women over 35 years old, 50 years old. So In conclusion, this is this is a suggestion, again in collaboration with anesthesiologists, before to do surgery in women with for hysterectomy or myomectomy, check the anemia, check the hemoglobin, and possibly restore the iron deficiency with a preoperatory infusion. So I think these three cases are explanatory of heavy menstrual bleeding. The gynecologist, in collaboration with the hematologist and general practitioner and anesthesiologist, are becoming aware of this situation. However, as mission of this webinar and of this society, we would like to explore in the future and to go furthermore to this discussion.
I would, that was excellent. Sure. I would like to make a comment, if that's okay, from your presentation, which I think emphasizes a couple of things. First of all, on the list of risk factors for postpartum hemorrhage, the WHO lists anemia. And as we mentioned already, the most prevalent anemia in this population is iron deficiency, which may have an impact on uterine contraction. The other is that we shouldn't just dismiss the fact that hemoglobin of 10, which I think you made the point, even though it's not that low, is anemia and still carries risks to these patients. Sure. And the last slide you showed is very telling because it's not reserved just for the GYN or the OB population. The Choosing Wisely campaign states that any elective surgery where there's anemia should be worked up and treated prior to surgery.
Absolutely, absolutely. There is a good question for Hilary, and very critical because it's a big discussion. You work a lot with FIGO now, with collaboration with SEUD. Why is it important to use a common terminology when we talk about MHB, menstrual heavy bleeding? Because this is really an issue for all the medical doctors.
So thank you for whoever asked the question from our webinar audience. I think why we feel it is important is it is a method of ensuring good communication. And we work across discipline, we work across the world, we work with many different cultures. And importantly, as you saw shared by my colleague, best clinical practice requires good evidence and good data. And if we're going to have good evidence, then we need a good classification and terminology when we look at the patients who are part of those evidence scenarios. Sure. And so unless we have some commonality, if you like, common language to describe heavy bleeding and symptoms of abnormal uterine bleeding, we are not going to achieve the best patient outcomes. And it also allows us to have a language to talk between physicians, to talk with our patients, to talk with the public. So we feel very strongly in both FIGO, and I think I look at Felicia, I can say for SEUD, that there is support for now using common terminologies so we understand what fundamentally is causing, as is the focus of this very webinar, bleeding and anemia and iron deficiency anemia.
One question also for you, just as we discussed, is mild anemia a risk factor before surgery? Because as you said before, 10 is still mild anemia. Is it still a risk factor, or we have to reach?
So again, if you look at, and there has been ample publications over the last 2 decades looking at different levels of anemia. We think of anemia being dangerous when it's life-threatening.
Exactly.
But in fact, it's not the danger, it's the risk factor, and it's almost linear. There is very good data from NISQIP, the Surgical Society in the United States, in collaboration also with the European publications, showing that there's a linear relationship between negative outcome, mortality, and morbidity as your hemoglobin goes down. So if you have a normal hemoglobin, you're at almost zero in terms of independent risk of anemia. But as the hemoglobin goes down, that risk of morbidity and mortality goes up. Sure. So it doesn't have to be 10, it could even be 11.
Exactly. Good. Hilary, this is a nice question also coming from a gynecologist, one of our colleagues. And she asked to both of us, what can I do to facilitate a conversation with patients suffering from heavy menstrual bleeding and identify iron deficiency anemia? So the question is what is the trick system to facilitate? It's not easy sometimes to interact on this topic. What do you think?
So again, we thank our webinar colleague for providing this important question. And it reflects, I think, the slide that was shown in the third presentation and the case history. Women can often go for many months, even years, and nobody actually asks the question. So I think this isn't going to be overnight. This is going to be a journey. And first of all, we need to talk about menstruation. So before we even come to menstruation becoming problematic, menstruation is a physiological event. It's absolutely natural. And I think across all societies, and I include the United Kingdom, and we have a lot of initiatives to really start people talking more about periods. That men, women, boys, girls, we all feel much more comfortable, because then women will feel enabled to not only perhaps judge their own personal menstrual experience when they perhaps may not even have recognized that it was heavy. And I think some women will go for many, many years before they actually realize that their periods were heavy enough. And that's why they have been feeling so tired, and they have been identified as being anemic and the cause not found. And so as we begin to open the conversation, talk about periods, we'll talk about problems of periods, and this will be identified then across both our primary care colleagues and in secondary care and cross-discipline.
One question technical for you, Aris. Normal hemoglobin and low ferritin. Do you think intravenous drip is useful for those patients?
That's a very good question. Again, I think we need to keep in mind that the development of iron deficiency anemia starts with iron deficiency. So these patients may be iron deficient for quite a while before they exhibit anemia. And in fact, we know today there is some data very suggestive that iron deficiency, again in cardiac disease, is associated with poor performance of cardiac muscle, and replenishing these patients with iron actually improves the New York Heart classification. And I think that goes for all patients. So the disease, if you will, starts off first with a deficiency in iron and then progresses to anemia. So a low ferritin with a known hemoglobin may require a little more investigation in terms of total iron, but there is nothing wrong with replenishing iron in someone who's iron deficient without anemia.
Okay.
On
There
the
is
contrary, it's
also a
something
nice
good.
question, how anesthesiologist and gynecologist collaboration needs to, how can be stronger? This is a very general question, but I think in our clinics we have a very good collaboration.
I think it's simple.
Very simple, very simple.
The collaboration is around the patient.
Absolutely.
And
absolutely.
identifying the needs of the patient, whether it's a surgical patient or not, we need to identify together.
Absolutely.
And converse.
And there is also a question for us if we accept the fellow in our centers in order to discuss. So of course we
Sure.
as university center, we love to accept. And there is also a nice point also on the awareness, on diagnosis and treatment in women. Awareness, I think in this case, the societies, as you said, the Blood Management Society, SEUD, or FIGO, I think all the many gyne, I think also hematologists, they are doing awareness. In women's health, I think probably this is probably a new field of interest, because as with Hilary, we founded together the SEUD 5 years ago. Yeah, we were the founders. And the discussion was heavy menstrual bleeding is not part of any other gynecological society. It's part of all the societies, but nothing special. So this is why we decide to have a society. We decide to have those webinars, educational webinars. So I think the awareness is absolutely one of the issue we have to take care in the future.
But I think to your point
Sure.
is the fact that, as we mentioned early on, you've got 3 other diseases in the world, such as cancer, diabetes, and heart disease, that have had recognition.
Exactly, high recognition.
And anemia is part of that club, and it is completely ignored still by the medical.
That's why we need awareness in the culture. And the final question, I think, because then the time is going over, is our hospital overall, including diagnosis of anemia, has in a timely manner before surgery in a checklist, pre and post.
So
checklist.
The earliest that we can make the diagnosis, working together with a primary care physician, for a patient going for elective surgery, it's recommended sometime 4 weeks prior to surgery, because that gives you ample time to have the proper diagnosis, because it may not be iron deficiency, or if it is iron deficiency, to again replenish the iron stores and get the hemoglobin up to normal. I've asked a lot of times, what is the target for the therapy prior to surgery? And the answer is to normal.
I think also in our clinic, a checklist, a pre-surgical checklist contains information on anemia. I think this is a common, most all of the hospital at third level hospital, we monitor anemia before to do any surgery. So I think.
So if we talk about checklist prior to surgery, I think that every modifiable risk should be on that list, including anemia.
Sure. So now we are really close. If there are no other questions from the team here, I leave Hilary to do some conclusions, because we explored all the different questions from the audience, and we thank all the people who answered, who posed this question to us. And now Hilary will give some conclusions.
So thank you for asking me to offer some concluding remarks. And I think, first of all, I would like to thank SEUD, the Society of Endometriosis and Uterine Disorders, for facilitating this conversation, our AV team for supporting us so seamlessly, colleagues in the team presenting to you during this webinar, and most importantly, our audience for all their questions. We've covered a lot of ground, and I won't pick up everything, I'm sure, but for me the highlights were that, first of all, we're having a conversation about heavy menstrual bleeding, about anemia, and this is so important. And in starting this conversation, hopefully we will continue it with our colleagues in primary care, in secondary care, across the globe, and importantly with our patients who, as I hope we've shared, are always our most important focus. Heavy menstrual bleeding is common. It affects 1 in 4 women. It takes women out of the workforce. It impacts their quality of life. And of course, we need to identify the cause. And if we identify the cause, this should help our colleagues who are presented with patients with anemia. I think it has been clearly emphasized that this is a huge burden wherever you live in the world. It is global. Anemia needs identification, underpinned by the causes of anemia, because this too has impact on broader clinical care and quality of life for women. It impacts them across their reproductive age, and we have had well shared the impact in pregnancy, how it may impact devastating outcomes of pregnancy, and also in gynecology and surgery. And I think a big take-home message is stop the bleed, or stop the bleeding. Identify the cause, and I hope that the FIGO systems will be helpful there. And there is an enormous value in patient blood management. And we shouldn't forget that our patients are at the centre of our care, and this is enabled by best clinical practice. And the Venn diagram we showed that this really is the underpinning standard we should all be aspiring to, underpinned by the very best evidence and the very best data. So I'm sure I've missed something in those conclusions. I just want to thank you all again, and again SEUD and the AV team, and wish everyone, wherever you're connecting from, a very good rest of the day or perhaps evening. So thank you on behalf of all
Thank
three of
you.
us.
Thank you.
Thank you.
We look forward to see you in Stockholm next May for continue the discussion.
Thank you.